gives me great pleasure to introduce our featured speaker, Dr. Rocky Rockstraw.
Wow. Welcome. First of all, I guess I'd like to welcome everybody here to the 4th annual UMDNJ-Tech Symposium. I was kind of impressed that I was being invited to talk down here. Thank you, Dean, for your opening remarks. I'd like to just thank a few different people and then kind of talk a little bit about what you all came here for. But again, my thanks to Dr. Joseph Barone, president of the I'm going to say Actors Guild. I know that's not right. The Masters Educator Guild. Dr. Boyer Bachman, Dr. Deb Josko. Did I say that right, Deb? Actually, all the committee members of the guild. And everyone that's put this event on. And I'll tell you, I'm not up here today without the efforts of Sheena Hines, who none of you know, but Sheena is my assistant who keeps me where I'm supposed to be at the different times. So I apologize for not knowing everyone's last name, but Noreen, are you here? I'd like to thank Noreen. I'd like to thank Lucretia. Is Lucretia here? I've seen April. My thanks to April. And my thanks to Ron Cody. Did I say that correctly? Ron has taught me quite a few different things with technology, and I know quite a bit. He's actually from my neck of the woods down in the Stratford, Fort Heaves area, and I just want to thank everyone for assisting me to get this on. So I'm here to talk to you about what is healthcare simulation. A couple definitions, and I don't know, do they have handouts for you on this, or is it available for them if they want copies of it, or I can make it? So here's a couple definitions, and basically it's just an imitation environment. It's trying to create as real of a feel environment for people to practice their skills, whether it's problem solving, critical thinking. Thanks. So here's just a couple different definitions that I looked up. But really, why do we want to do simulation? It's not cheap. It's not cheap at all. And I remember when I first asked my boss, the dean, and my at the time director of undergraduate nursing to spend the $60,000, they kicked me out of their office because they couldn't see the value in it. And it is a pretty big investment. But we look at it. We all know that there's a patient safety issue out there, and that there's concerns. And I think this afternoon I'm going to talk a little bit more about its relationship to patient safety, specifically standardized patients and human patient simulator, but also in what they call crisis resource management or crew resource management. That actually comes out of the military as well as flight simulation. But medical errors, it's not and that's general medical error. I'm not talking about medicine or physicians, but I'm across the board: nursing, physical therapists, hospital systems errors, organization errors, or what have you. It's very complex, and intertwined in it is human nature, human behavior. And I want to begin to talk to you about those issues. But I think what we're able to do is to recreate that environment, allow us to go in there and just play and get comfortable in what we're doing. You know, one of the big issues in medical error is our inability to respond to an unusual critical environment. Well, if we practice those high-risk or unusual environments, it won't be new to us when we actually receive it, when we actually experience it in real life. We talk about simulation being clinically safe. It's clinically safe. You can kill a simulator. You know, in nursing, we don't like to kill a simulator. I'm against that. People die. I think simulators should die, but I can bring them back to life. It's clinically or psychologically safe when you're working with actors, because when you say the wrong thing, when you misdiagnose in simulation, when you get excited or maybe your mannerisms are off a bit, the SPs are trained to look past what is said or how it's said, and to train the provider in how to better give bad news, how to better question and what have you. Is it psychologically safe? I think it's very psychologically safe. In that it's a place to practice my profession. If I'm being evaluated for clinical competency, whether it's at graduation, whether I'm being trained in clinical competency as part of my job, is it psychologically safe? You know, I think it depends on your comfort level and what have you, but I think we really need to look at that. And one of the exciting things, I think, one of the challenges we have, and And I was impressed. I was looking up, I believe in the UMDNJ website, is a lot of you at this university are already doing a lot of novel ideas with clinical education, with general education, with debriefing skills and what have you. So I think you're halfway there, but a lot of us are struggling with that debriefing, that guided reflection, creating that safe environment to be able to talk about my mistakes and what I did wrong and how I want to correct that. In academia, we do it all the time. I think we do it all the time. But think about that for a minute. I'm a PhD prepared nurse. And I'm going to go in there, and I probably couldn't start an IV today. I've been out of clinical practice for 8 years. And I'm okay with that because, it's a dull practice and until I get confident with it. But what about my ability to show some of my junior faculty or some of my junior nursing students my skills and what have you? And am I comfortable with that? I would say yes, but I'm probably not a normal creature. I'm probably not the normal person that, I'm in my position. So just a couple different things. And when I was invited here, I thought about this once or twice. How many technicians, keep your hand down, Ron, how many people are IT specialists, whether it's by title or just by behavior? How many people love IT, love computers, again, would get a brand new Mac or computer? Well, I think a simulation lends itself to that, and you need a good, strong point to that. And I just wanted to talk about how simulation kind of affects the IT world and how it incorporates in clinical simulation. I just broke it into input and output, and from an IT perspective, it's pretty basic. Some of the simulation that's out there is for input for the technology to receive information in is like body tracking, and you may have seen it. They have full body suits, they have headgears or helmets, they even have gloves to track a human movement, even with fingertips. We're using it not just in clinical training, but they're actually doing it in robotics, in surgery and different things to be able to perform surgery at a distance. And in my travels, I was just talking with Joe earlier, and down in the South Jersey area, I'd like to actually witness, I haven't done it yet, some robotic surgery, because I really am not sure I understand the concepts of how it's being used as far as from a simulated environment. Because really what you're doing is, even though that the robotics is within probably 5 feet of the actual OR table, that is a simulated environment receiving that information in. They've even doing research with tracking from the movement of your eyes as well. Physical controllers, those are what you may not think about, but anything from a gaming tracker or what have you are the mannequins, the computerized mannequins that actually receive, they can sense you feel a pulse, they can sense a defibrillation, they can sense CPR, different things. Those are different forms of input as well. They actually have voice and sound recognition as well to be able to activate different types of simulation. And the reason I say that is in my experience of lab design, these are different considerations that you really have to understand. How are you going to receive data in for the technology to understand what's going on, how the clinician is interacting with the person, and how they're going to respond back, which leads me into the output piece. And I'm going to kind of go through this a little bit quickly, because again, I think sometimes if you're an IT expert, you want to talk all day about it. If you're not an IT expert, it's like, come on, get to the good stuff. So we can talk afterwards down in South Jersey. In output displays, visual, it sounds pretty straightforward, but you'd be surprised what's out there for visual output. Something as simple as your computer screen. They have typical computer screens as well as large screens. They actually have what they call caves, which is a 360 screen that goes around you. So whenever you're turning around, you're able to see the different simulation pieces. Whether you're looking down a street or looking in a room, and you'd be able to move around. They have a hearing type of simulation. And what that is we used to struggle with that. When we first had our simulator, our faculty would stand behind curtains, so the sound would be coming out of the curtain and not the patient. So the students, rather than looking at the patient, would be looking over at the curtain, because that's where the sound's coming from. And it makes sense. They could kind of see someone back there, the Wizard of Oz, the man behind the curtain, or what have you. But one of the things I did that was exciting when they gave me probably about $1.5 million to design our simulation lab, not our standardized patient, but our HPS, is we're thinking about the sound, and we're able to, not quite 3D, but getting close there, where the sound can come from the actual simulator, from the mannequin. Sound can come from overhead, right overhead on the bed, or the sound can come from kind of the end areas of the room. And our simulation rooms are we have 2 of them about half the size of this room. And the reason that we did that is because we have a flow issue. I don't take 5 students at a time. Sometimes I take 20 or 30 that are in there, and we can run 1 simulation or 3 side by side. The haptic is really tactile. So the input or the output, you're able to feel a pulse, you're able to feel vibrations, even something as simple as temperature. And we as clinicians, that's very important to be able to touch something, and does it feel room temperature, does it feel hot, does it feel cold, or what have you, will help in that clinical experience. And then the last part here is as far as motion. And we don't use that in clinical simulation yet. But that would be like your flight simulators, the car simulators, to be able to feel it roll and pitch and different things like that. A little bit of a history for healthcare simulation. It actually dates back, and I have not been able to base this in the science, but through just a little bit of the readings, they actually say that it dates back to 3000 BC when the goddess Isis was kissing her husband, or as a healthcare profession, we want to say breathing the life back into her husband after he passed away, or something like that. So they say that may have kind of been the impotence, or at least what we want to say is the first part of a CPR or a simulation environment. It really started in the 1950s, and a lot of what we do in simulation we actually get from our government and from our military. Whether it's aerospace, post-World War II, in the 1950s, it was the birth of the analog computers before what we have today with our PCs and Mac. Kind of like your early ECG machines and bedside monitors and things like that, as well as your flight simulators. 1960s, what's unique, and I think I'm going to talk more about it this afternoon, is it showed the advent of not just the CPR and defibrillators and chest compressions, but the standardized patients. Anybody here not familiar with the standardized patient program? Never experienced it, and it's okay if you didn't. I'm not seeing any hands. What's unique about simulation that we can't do in healthcare? In Mississippi we can, but I won't go there. I lived there for 6 years. Is we can't provide a standardized patient. I can't make patients sick purposely for my student experience. I can't control the output that the students get from the patients. You can do that with the standardized patient. But actually standardized patients came from standardized instructors, because a student would learn how to do a health assessment from me. Let's just say take a blood pressure. And I would teach steps 1 through 5, and then a second instructor would teach the same skill, but completely different with the motor skills, and it would be very confusing for the students. So the standardized instructor actually came out in the 1960s, and they morphed late 60s, early 70s into the standardized experience. And again, what's unique is whether it's 5 students or 500 students, I can provide the same standardized experience. It may not be identical, but pretty close. And the only difference it's going to be is how the student responds, whether the student interacts for 5 minutes or 50 minutes. That's what's going to be the change of the experience. You may not know it, but there's simulations for PowerPoints. There should be on those as well. Power plants, and it sounds kind of crazy. You know, why do we do simulation? It's either high incident. It's either too dangerous for us to practice with the real things, whether it's or it's inaccessible. Inaccessible, like aeronautical, getting up in space. It's inaccessible, so we're going to simulate it. It's too expensive or too dangerous to put a pilot for his or her first day in a plane. And it's in my mind, I think it's dangerous how we do clinical training, where we put novices on day 1 in charge of patient care. I think we do a great job at trying to safeguard it, but I just think that it's something we've got to think about doing differently. There's military flight simulators, anesthesia simulators. So it's the task trainers, whether it's with anesthesia, whether it's with surgery, whether it's starting central lines or IVs. Those really became, birthing really kind of jumped to the forefront in the 1980s and 1990s. High risk, high legal issues, high mortality. The computerized mannequins, the full-body mannequins, really didn't come out until about the late 1990s. You may be aware of this as clinicians, but I find out in my travels, and I talk a lot more to nurses or what have you, but back in the 1990s, we, through our government, Uncle Sam, paid multi-million dollars at that time for this transverse sections of a human body, human cadaver. And I think they actually did it at either a 1/4 inch or an 1/8 of an inch. And we really integrate this in a lot of our A&P, pathophysiology, and some of our nursing courses. But I think it's really exciting. It's free. There's a website, and it's considered a low level of simulation. I'd call it a no-fidelity simulation, but it's still simulation to be able to look at the body and to begin to critically think. The 21st century's brought on a lot of different types of simulators. There are many different simulators. The two, in my mind, major players out there, and there are many additional players, is Laerdal and Medi, and those are the vendors. But more importantly, behind the scenes, Laerdal is PC-based, Medi is Mac-based. And again, for the IT buffs of us, Laerdal is much more configurable, much more easier to use as far as to make it do what you want it to do. Mac is much more intuitive, Medi is much more intuitive, but what you see is what you get, and you can't alter it. And Mac is actually changing that as well, or Medi is changing that. In the last 5 years, our simulators become tetherless. So instead of having it connected to compressors, connecting to the wall, we're using Bluetooth technology. We're using wireless technology as well, which is exciting. But again, those are infrastructure issues that you have to deal with. In Washington, D.C., the National Capital Area of Medical Simulation works a lot with our military healthcare professionals, Navy, Air Force, Army. There are no healthcare professionals in the Marines. They use the Navy. But they're also doing it with Secret Service as well for presidential and VIPs. And it's really exciting what they're doing. And they're one of the first non-military folks who have built a cave for the clinical training down there as well. They'll have a simulator helicopter coming down, and the participants turn around, and there's a helicopter there that they have to remove the injured. They turn back around, and there's an ambulance that they have to put them in, and they take them to the hospital. It's pretty wild with what they're doing. But it's a lot of work. It's a lot of fun as well. Surgical virtual lap coles, the simulator's not been around that long, and there's been iterations of it, but I think the more recent models, early 2000. Virtual reality, Second Life. Anybody heard of Second Life? It's great for gaming. I think it could be great for clinical training. As an administrator, currently I'm reinvestigating it, and my current belief is return on investment. Too expensive. I'll give you an example. You got a website. You want to redesign your website. And it's just been the last year that I'm no longer responsible for our website, but for the first 10 years, we redesigned our website 3 different times in 6 years because as technology is out of date. The cost to redesign a website is phenomenal. But the image, not to do that, may have a reflective piece as well. So what you do with Second Life, I think it's great for gaming and what we can do, but the ability to make it simulated. I attended a conference. We actually put on a conference in March, and I attended what some folks in, I think, Kentucky are doing. Phenomenal, but they're simulated Second Life, and they spent hundreds of hours. As you walk up to a simulated patient in Second Life, and you touch it with your mouse click, it'll give you a blood pressure. You touch it again, depending on touching it at the head, and it'll respond to you. But it's very, what I would call low fidelity. You know, it's fun, it's gaming, but it's nowhere where we need to be with clinical simulation. Bottom line, future of simulation, the current, is patient safety. I've got to be able to sell to you, I've got to be able to sell to my dean how simulation translates into patient safety. And the news is research doesn't support it. Ouch. Let me be clear, and I'm going to be clear because I know I've got nurses and physicians in the room. When it comes to tasks, central lines, surgeries, intubations, improved patient outcomes are definitely there. When it comes to crisis resource management, and we're a team. I was talking with Joe and a few other folks last night. I never played team sports. I was like the guy in high school, you know, with the pocket guy with the pens and the Velcro and everything else. And I thought I was pretty cool. I wasn't even on the chess team. But as healthcare providers, we're one big team, and it doesn't. And the team environment is. It's not about me. It's not about the quarterback. It's not about the head basketball player. What do they call the quarterback in basketball? Point guard? Point guard? It's really not about us. It's us getting that ball in the hoop or getting the ball down the end of the field. In patient care, it's about patient safety. And if I was trained as a physician that I have the authority and the responsibility to be an individual team player. And I remember when I went through my nursing training, and this was back in the 80s, not too long ago, that we had a physician come in and talk to us and say that his training told him not to trust nursing. Not the individual, but the ability to be completely, he didn't use the word honest, but basically the ability to translate our what we're seeing, what we're hearing, what we're feeling into a logical. So they had to interview us. He was trained to interview the nurse just as much as he would the patient to try to get the information they needed. And that says something. And I think what that really says is that we've got to stop training in silos, that we have to start training or experiencing or playing, I like to say playing, in a simulated environment so we can become that team of healthcare providers. And we have to be able to show it and demonstrate it, the patient outcomes. There's a lot of research showing that I feel good about it, good self-efficacy, good self-concept, but is still out there as far as being able to scientifically say that there's positive patient outcomes, that it's actually changing the face of that, and we need to work on that. So here's just a few different pictures of some simulation from left to right. The left is actually Second Life. You know, it's funny, when I first investigated Second Life, Drexel had an island in the shape of a dragon. That's our mascot, Mario the dragon. When I attended this conference in March, I can't find the island. So again, I'm a little behind the times on using Second Life. But we use simulation, and then the next over is a lower fidelity computer-aided training, what they call CAI, computer-aided instruction. And then on the right, top to bottom is, I think that's MEDI on the top. And you can't change the simulator's faces. You can put wigs and glasses on there, but there's no changing that look. And I actually had a picture of Noelle, and Noelle's a birthing simulator. Her early face was god awful, but she birthed a baby every 10 minutes. It should be. It should be. And then actually below is a hybrid birthing simulator as well. Oh, and I'm sorry. Let me. So I'm going to talk to you in general for the next half hour. So just breaking it down from training to what I call low fidelity. And those are my definitions, because out there it depends on who you're talking to and what area you're in for simulation. And in my idea, low fidelity would be partial human simulator, or they only receive input. They only give output. They don't interact with the environment. They don't receive input. High fidelity, bless you. High fidelity is both input and output, and that's the way that we interact with the simulator, and a little bit about the standardized patients. And that's kind of how I want to divide this up. So training task trainers, you may be aware of this. Over 30 years ago, still state-of-the-art Harvey. Harvey's a mannequin output for basic skills, cardiology, palpation, auscultation, EKG. Very, very great, very state-of-the-art, still very expensive for some people. But again, I think it's well worth the $60,000, $65,000 and he's out of down in Florida. I can't remember the name of the university that actually created Harvey. Hands-on for sutures and IV trainer advanced. Out of curiosity, does anyone have the IV trainer from Laerdal be able to start peripheral lines? You've got it up there. I'm going to show a video clip. This is my only disclosure. The first 2 seconds will show the company. I'm not selling the product. But I tell you, Laerdal has done a great job at this type of simulator. And I've been trying to get this simulator at Drexel for the last 8 years. And the reason that we don't have this simulator is in the state of Pennsylvania, IV starts is regulated to the hospitals, not to the academic institutions. So we don't teach it, we don't train it. But I think it would be great for our physician assistants, our masters of nursing, as well as our undergraduate students for practice. So this is just about a minute and a half video clip. Pay attention to 3 different things: the visual cueing, seeing what you're doing. There's actual the holding of the IV. And you actually will feel it, you won't feel it, but with the simulator you actually feel going into the skin and the pop of the vein and what have you. The only drawback in my mind for this piece of simulation device is that typically I'd be working in front of me here with an IV, but with the simulator I tend to be looking over here, but I think that's minor. If your hospital doesn't have this, if your academic institution doesn't, I think it should be required.
The Virtual IV is a comprehensive and fully interactive simulator for training intravenous catheterization. Powerful 3D graphics provide visual realism, while a proprietary force feedback device accurately simulates the sense of touch for a truly immersive experience. Unprecedented depth with over 150 distinct case scenarios, each themed to in-hospital, pre-hospital, and military careers, and over 40 unique patient models that span human anatomy and physiology. Virtual patients respond with physiological reactions based on your interaction with virtual anatomy, pre-existing conditions, and the specific case scenario. Vein compromise, infiltration, bruising, and vein rolling are just some of the pathologies and obstacles you will encounter throughout learning. A host of other complications force the learner to respond appropriately while adding depth and realism to the learning experience. The procedure is performed with over 24 pieces of virtual equipment and additional procedural tasks appropriate to IV catheterization. Clinical accuracy is achieved with site-specific assessment, interaction, and response.
I'm going to stop it there, but I think a couple things in my mind that's exciting about this is not just the basic skill of starting an IV. And if you've ever been on the receiving end of an IV, it's pretty scary. I'll tell you, that's the only thing I'll break out in a sweat. I mean, I've had minor surgeries and what have you, and thank goodness for anesthesia. But I don't mind blood draws. But when they come to start an IV on me, there's a specific skill. And and it's almost like how many times have you started an IV, and how many times has it been successful, and what's your infection rate? But what's unique about this is not just the basic skills, but the simulation changes depending on some of the pathophysiology of the simulated patient. With diabetes, you can blow the vein much more easier. There's a simulation in here for a IV drug abuser, and it's difficult to get through the skin, and you can't find the vein. And it actually changes the mechanics within that haptic device depending on the different simulation. They also do it for gerontology as well as infant IVs, and I think that's pretty exciting. And I want to be able to say this is not the first time I started an IV, the first time I did, because I've practiced it 100 times on this IV simulator. I'm just curious, does anyone wish they would have had something like this in their training? And the reason I say that, show of hands, and the only reason I say that is I remember I trained back in the state of Nebraska where it was part of the curriculum. And probably jumping, any lawyers in here are going to jump, we used to practice on each other. It was voluntary, so they say. Go to another school if you don't want to do it. So we practice on each other, and I only had 3 IV starts we were required on each other. And I still talk to my friend who I tried 3 times on her, and 3 failures. And that was enough. But it's a challenge. It's a challenge, and I think simulation definitely would help us in that area. Other type of chest trainers with intubation for anesthesiology, with the task for the important but yet task-specific, surgeries, whether it's laparoscopic surgery, GU, GI, whatever that might be, bronchoscopies, even just the computer-aided training. And I think that's unique, not just from my perspective. It's fun to get in there and play and try to be a surgeon, and I don't have to be trained to it. I can just get in there and kind of have fun and play around and tie knots and cut and do different things. And in all reality, it's not just a skill. It is a skill, but more importantly, it's what do you do with that skill when something isn't working, and how do you respond to that and react to that? And again, in my belief for patient safety, the first time my surgeon experiences an abnormality, I'd rather it not be me. I'd rather it not be anyone. I'd rather it be in a simulated environment. And then advanced cardiac life support actually does stem out of simulation as well. And I think that's critical. I was talking, again, during our conversation last night, or maybe it was earlier in the day at Rutgers conference. And I'm a junkie, too, when it comes to critical care. I was ICU, trauma, ER. If there was a code going on, I was the first one to respond. Now, early in my training, I wasn't. But we were talking about the fear that sometimes if you're not used to frequent critical events where, you know, a CPR is required, advanced ACLS, cardioversion, or even in the trauma. And how do we help people pass that? How do we help our colleagues? And it's not just past the fear, but I think it's the fear of not feeling competent. You may have the clinical skills, but if you've not experienced it, I think simulations goes quite a bit to assist us in feeling comfortable and confident and competent as well. In low fidelity human patient simulators, they do a lot of different things to produce a normal or an abnormal event, whether it's sounds, vocal sounds. I was talking to someone this morning that they actually use one of the simulators for mental health, and I think that's difficult only because there's so many different replies and so many different speeds of speech and so many different nonverbal effects. I'm not saying that we can't do mental health, but I think our actors lend support to that better than the computerized mannequins. But you can do that. You can change normal, abnormal heart sounds, palpations, and different things, both tactile as well as hearing, lung sounds, gastro sounds, and what have you. Now, again, depending on the simulator, my personal experience, I'm not promoting anything, but again, Harvey, as far as lung sounds and cardiac sounds, state of the art. It sounds real, normal and abnormal. Medi and Laerdal, they do a great job. Not quite, and I don't know, you know, it's one of those guarded secrets with Harvey, but not quite, but they do have the different simulators out there that help produce it, so at least the first time I hear an abnormal sound is not on a real live patient. Talked about the palpations, about the experiences as well for low fidelity. You can do IV therapy, you can put NG tubes down, you could actually do surgeries on a lot of these simulators, you can do birthings and different things, but it's all output. It's all experiencing it, and it's not being recorded, and it's not being interacted with the individual, the clinician, the physician, the nurse, or what have you. As far as high fidelity, you still get the same experiences as the low fidelity, but the input is different. And what I mean by that is you're also able to intubate. And you can do a normal intubation, or you can do an advanced intubation. And for me, an advanced intubation is you can have tongue swelling, you can have vocal cord edema, you can have strabismus, you can have, what's it called when they wake up and they bring their neck up? Is that strabismus? Any anesthesiologists here? Anyway, anything that you could do, you can blow a lung, you can intubate the wrong lung. And again, those are things from a novice or someone who hasn't experienced it that I would rather experience on a simulator here. I know, as far as not just fluids, but even just input and output, when we talk about debriefing a little bit later on, and the ability to, yeah, I started an IV, yeah, I intubated the patient, yeah, I started a Foley catheter, but maybe it's critical in your training in the order that you do that. And maybe I didn't do it in the right order, and here we're able to document objectively what actually happens during the experience as well as the pathophysiologic responses to the interventions. Laerdal has a great product where you're able to configure the mannequin, and you can have them react to a medication that you might give or an intubation that you might give. So when you intubate, you program the computer, and the heart rate goes down, the respiratory rate goes down, the SATs go up, whatever you want to appropriately happen or inappropriately happen depending on whatever the intervention is. But that's programmable by us or some type of technician. Medi, which is Mac-based, and I'm thinking about the, it's copyrighted HPS, but HPS in the literature actually stands for all the mannequins. But the Medi HPS is a $230,000 anesthesia machine, and what that does is not only do you bar scan the medication, but when you're pushing the IV, it senses the amount of fluid you're giving, it senses the speed that you're giving it, and so that mannequin, without you configuring it, responds pathophysiologically to the medication, to the treatment. I think that's pretty phenomenal. Now, we don't have one of those there, and early on, I wish I would have had a Medi. But in hindsight, I like the PC-based, and the Mac-based, which is the Medi, is coming around because early on with the Mac, you couldn't change it. If the student killed the mannequin with the medication, there was no way for the faculty to override that. They had to actually go through whatever the pathophysiology response and wait for it. And I think from an educator perspective, this is my personal bias. During Joe's introduction, he told Joe, I don't know how to stop going to school. But I've got a couple master's degree and a baccalaureate degree. It's all clinical. But until I started my doctorate, I didn't realize that as an educator, I was a novice. I think my students would probably tell you something else, but I didn't know that what I didn't know about education. And what I like about clinical training with the simulators, especially with the Laerdal, is I control it. So when I have a strong student, I can challenge them even stronger. And when I have a student that's weak, that I'm concerned about just getting them up to the safe bar, and that's sometimes what we have to do, I can slow the simulation down to build their self-confidence, to build their self-efficacy, and hopefully get them to where we need to go to be a safe provider. And I think what's critical, too, is the ability to give feedback. And what I mean by feedback is to be able to see in a controlled setting afterwards what my performance was in the order that I did my task or skills or interactions. Standardized patients are live actors. You probably know about that. And I'll tell you, nursing's been slow on the use of standardized patients. Standardized patients have been in use in medicine since 1960s, 1970s. I think there was a few programs just investigating it, getting a grant and trying with 5 or 10 students, nursing students, with the standardized patients. At Drexel, we don't do anything like that. We just incorporate it into the curriculum. Back in 2001, Dr. Mary Ellen Glasgow, who actually just recently, she was our associate dean at Drexel. I think she just accepted a deanship out at Pittsburgh at Duquesne. But she wrote into our undergraduate nursing curriculum a mandatory, kind of like an OSCE, where it measures the student's skill and the ability to whether it's the interview techniques, the assessment techniques. We don't provide diagnostic diagnosis, but we do clinical reasoning in the back of our mind so we can educate our patients, and we've been using that since 01 or 02. And we were the first at Drexel to have a separate simulation lab for standardized patients. Our medical college has one, and I think they've had one probably since the 60s or 70s. And we built our own. We were using it so much in 06. So we were the first, I believe, School of Nursing, College of Nursing, that had a standardized patient program separate from the medical college. And I think it's really starting to change the face of healthcare. You may know this, you may not. As of 2005, you cannot become a physician with not just demonstrating your book knowledge with a test, but now, before 05, you weren't required to do 10 OSCEs. As of 05, you cannot become a physician without successfully demonstrating your competencies at some level. Medicine's so far advanced in those aspects than nursing, and I think we're behind the ball on that. Our state boards of nursing with the NLN, National League of Nursing, with I think Laerdal, are doing some research to change that to see if we can start requiring some form of performance-based evaluation prior to putting nurses out in the field. And I think that's definitely needed, and I think that should just be the beginning, not just for licensure, but I think, I don't know if it's annual licensure every 5 years, but I think we need to be able to prove our competency for patient care. And I'd be happy to talk to you about that after the presentation, because I know that always kind of sparks some thoughts and ideas. And I should be held accountable and competent in my ability to instruct to my students. That's a whole another novel idea. My dean says I can build her simulation on how to fire faculty, and she'll work on that. Competently and compassionately. So how do we do part of that behavioral piece of us, or that social piece? I think it lends itself to the standardized patient. Many times it's non-invasive. You don't really start IVs. You do hybrids. We actually take IV arms in there, so when a student goes in to start an IV, they have to interact, interview the patient, and then when they get ready to start an IV, the actor pulls out the IV arm and has the student practice on that. It is a standardized experience. There are some standardized patients out there that we call MEDI, or it's different though, and what they do is they're actually standardized patient instructors where they teach invasive exams like gynecological, rectal, GU type of exams, and they get paid accordingly as well, which I think they should. Just a little bit about the simulation environments. Whether it's a task trainer, and you can see that's up here, whether it's an individual experience for the standardized patients or the group for teamwork. I think those environments are definitely high on tech. But I think, so the task trainers, you're just going in there and you're performing a task. You walk up, you don't really have to really interview the patient. And even some of our undergraduate nursing students, when we first started using this, we would have them go in and do a certain task, like just go in and do a cardiac assessment. And of course, as many students do, in my experiences with nursing students, is what is it going to be? Is it going to be on the test? What am I going to be graded on? I'm very nervous. So we actually would tell our students, you know what? You're not being tested. You're being tested on your ability to perform a cardiac assessment, physical cardiac assessment. You don't have to talk to the patient. We actually had 2 students early on that were walked into the room. They were so nervous they didn't say one word to the standardized patient, and they still were very successful because they were being graded on their ability to perform a cardiac assessment. And those are some issues that we worked with separately with the students to be able to get that comfortable piece with the advances, what have you. But the task trainer is just that. What is my task? What do I need to accomplish? Whether it's a surgery, whether it's an IV, whether it's an assessment. Then with the individual experiences, and from an educator perspective, when you come to my sim center, I'd rather you not say, I want to use the mannequin. I want to use an actor, and this is what you're going to fix for me out in for my students or for my providers. What I really want to know is what the objectives are. And if you're an educator, that sounds really exciting, but you don't want to develop a class until you understand what you want to accomplish, what is your outcomes, what do you want to. So when I think about the simulation environments, I think about individual objectives, individual outcomes in the standardized patient, whether it's interview skills, whether it's developing a relationship, whether it's some type of diagnostic reasoning, physical assessment, or what have you. And then I think about teamwork or group work or crew resource management, closed-loop communication when I think about the human patient simulator. Not just interacting with the patient, but maybe a patient and their family members. Maybe a patient, their family members, and what we like to call confederates, whether they're doctors or nurses. And again, they could just be part of the scenery, or they can actually be some of the main objectives, whether it's dealing with a difficult charge nurse or dealing with an incompetent provider, whatever it might be. And it may not be an incompetent provider, but a provider who doesn't have the full information is making the wrong decision. And how do you jump in there to give them that information when they're too busy and it appears that they don't want to hear what you have to say? I think this is one of my last slides for this morning. And I spent a good part of about what I was talking about on the simulation itself. But my experience, my personal belief is without appropriate guided reflection, feedback, or what have you, I don't want to spend time in simulation, because this is where a lot of the hard work happens, is when you start dissecting what happened, what went well, what didn't go well, what can I do to improve it. So when I think about feedback, guided reflection, and debriefing, and I'll talk a bit more about that this afternoon, I talk about a safe environment. How do you have a safe environment for a 20-year scholarly physician or a 50-year scholarly nurse, and say, you know what, you might not be up on your game, and let's talk about it, and let's get you to where you need to be. And that's going to be difficult at times. And Drexel's nowhere near where we need to be. I think we're definitely making strides. Harvard University School of Medicine, College of Medicine is doing phenomenal work in providing what I'm calling a psychologically safe environment. And what's unique is there are no physicians who are leading it. I'm not saying that they're not clinically competent, but one is an organizational behavioralist, Dr. Jenny Rudolph. One is an educator, Dr. Robert Simon. And I call him the granddad of simulation, Dr. Dan Raymer. His background is biomedical equipment. And what they do with the simulation is not just the simulated environment, but just more so the debriefing piece, the exploring the piece, trying to get me, the participant, past the, I screwed up, I made a mistake, I'll do better. Kind of start peeling back the layers of the onion. Why did I do what I did? Why, when a nurse came to me and gave me some information, that I either ignore it or I didn't hear it? Or why do I know when I was trained yesterday in disaster preparedness that I'm going to be the leader in the room and I'm going to stand back and not do any task, but yet during the simulation today I became very task-oriented and I didn't handle the scene like I should, and start exploring and discussing and kind of working through those kind of issues. Oh, okay. I forgot to tell you, my nursing students at cringe, there is going to be a test. And unfortunately, I'm not joking. I found out last Thursday that they're providing I'm going to get this wrong, CME, CE, CME, and CE for nurses as well. So I'm going to go through and share with you the questions that you'll be asked in some of the documents that you've been handed out. If you have it now, let's work on this together. Okay? So this is going to be interactive. So my first question is, what are the 4 types of general simulation hardware? And from an IT perspective, we're going to be excited that you know this. 1 being body tracking, sound recognition, and voice recognition. 2 being visual, oral, haptic, and vestibular. 3 being Blu-ray, research, aerial, and haptic. And 4 being video, printer, server, and body tracking. 2? 1? 2? All right, so 2 it is. So if you have those document with you, you might want to fill that in. It's your choice. Simulation promotes patient safety by. Now be careful, because I spent some time on trying to trick you on this one. Not really, to make you think. Simulation promotes patient safety by providing multiple chances to correctly diagnose illnesses. Simulation. Ensuring all healthcare professionals work together. Providing a clinically safe environment to learn, practice, and become proficient in your clinical skills. Or stimulating the human senses to acquire new knowledge and skills. Right. I think I'm hearing the answer, and it is 3 or C, or whatever I provided for you. Very good. So far, 100%. The term standardized patient evolved from the earlier modality of standardized instructors, experiences, simulation, task trainers. A, B, C, or D? All right. What I'm hearing, which is exciting, as a faculty, is I need to work some more because I did not do a good job at giving you this knowledge or information. But it actually came from the standardized instructor back in the 1960s. Again, from an administrative perspective, I would, rather than pay faculty now $50, $60, $70 an hour to teach my students in a standardized way, I can pay patient actors, and in the Philadelphia area, we're paying them $20 an hour to provide this standardized skill instruction. I'm not talking pathophysiologically, I'm not talking about diagnostic reasoning, I'm talking about this is a stethoscope, this is the diaphragm, this is the skin, this is how the diaphragm goes on the skin. Important early on clinical skills. So the answer is instructors. High fidelity human patient simulators include all of the following abilities except, so this is, we're going to select the one that's not true. Ability to reproduce normal and abnormal, endotracheal intubation, pathophysiologic responses to interventions, guided reflection feedback. D, B. Okay, by Rocky's definition of high fidelity, it's actually D. It's actually D. I'm sorry, was there a question or comment?
Well, I said if you were the voice of the mannequin could stand in and do the debriefing, correct?
Sure.
That was being funny.
Yeah. No, actually, you're true, and I think I probably created this question with my whole day in mind, because this afternoon I'm going to talk about some of the best practices in debriefing. And I remember the first time I was debriefed in a real-world environment where my patient coded and died, and we had a healthcare professional come in to debrief us, and we stood around the body right after CPR was stopped, and I was like, okay, how'd it go? How are you feeling? Any questions? And that was what we call debriefing. But the best practices of debriefing, whether it's in a simulated or real-world environment, is away from the environment. You can't always do that, so we struggle. Why don't I have one room? I'm not at Drexel, and I think you want to move towards that, but good answer. Here's a few of my references that I use. These are actually books, and I would say if you're a scholarly person and you've been challenged to create a sim center, you've been challenged to integrate this into the curriculum, not just a scenario to using it, but to really, from the ground up, I really did my limited this, and I think every book on there, and a little self-building. That last book on the bottom is a little bit more recent. But what we did from there is right above us. There was, when I look for textbooks and stuff, there's a lot of textbooks out there with human-patient simulation, the mannequins in the simulated environment. But it was difficult for me to find anything in the standardized patient as far as a textbook and the training and the use. And Dr. Wallace, out of 2007, but I think this book, originally her first iteration, is from back in the late 90s, talks about coaching and training the standardized patient experience. And Linda and I, Dr. Wilson and I, we did the opposite, and rather than training the standardized patient, we talked about how to build and create scenarios for all healthcare providers, God bless you, from nursing to medicine, from U.S. medicine to, we actually have some folks from Spain and somewhere else who talk about anesthesiology, physical therapy, creative arts and therapy as well. So I think that's enough for me. And this is actually the first time ever. I think I stopped with 10 seconds over instead of 10 to 15 minutes. Am I good? All right. So, questions and answers? Thank you. Thank you.